This morning, I'm honored to present both friends and community partners for this event, Ken Seeley McLaughlin and Eric Seeley McLaughlin. They are some of the first people that I met when I entered into this recovery industry, and they've been very, very supportive throughout the year of all the Palm Springs community and nationally. And I'm going to let them introduce themselves as they're going to introduce the topic. But when we were talking about how to reach out to marginalized populations within the LGBTQi plus community, I thought of them, because they're interventionists and they've intervened with a lot of families and have given a lot of support throughout the years to people who are still suffering out there. So without further ado, I'm going to turn it over to Ken and Eric.
Thank you, Renee.
Yeah,
Both
thank you.
Renees.
You guys have been working so hard on the conference, and to see everyone come together and support the conference has been really exciting. So we love that you guys put in so much effort and heart into this because it's much needed. So.
And the results are showing. That's exciting. So thank you. And thank you everyone for showing up this morning. We're excited to spend the next hour and a half with you and answer any questions. So if you have any questions as we're going along, throw them in the chat. Eric's really good at monitoring that.
Yeah, if I get a glazed over look and it looks like I'm not paying attention, that's why.
Like he was just doing.
Yeah. So I'm Eric McLaughlin. I'm a ASW, which means I'm working towards my licensure in clinical social work. Also a certified intervention professional and a certified case manager interventionist. I really have worked hard to understand a few things. And one is the importance of families and long-term support for recovery from addiction and mental health issues. And we're going to touch on both of those as it pertains to LGBTQI communities today.
And we know a little bit about that as my husband's right here.
Yep.
And so
he's blessed.
And really excited to be here with you guys because, we realize that our community is really struggling right now, not only because of COVID, but with our addiction. And when you add, crystal meth to gay sex, I mean, it's just, there's so much going on. And, the lesbians, the trans, everybody out there, people struggling with their identities. It's really, really difficult right now because you don't have the groups. I remember back in the day, I'm going to age myself here, but back in the day when I came out, it was more about, going to clubs and going places and meeting my peers and, connecting with each other. And, that's how we met in a bar. So, now not to be able to do that this past year and being isolated and being home alone or hooking up on the apps, that's another big one right now. I know somebody that, hooking up on apps and then they, got nervous because of the COVID, now they're putting their life in jeopardy with COVID happening. So all of these things that are happening right now, we're suffering with addiction, mental health issues, and we really believe that there is some help out there. Mm-hmm. And like Eric said, our biggest part is believing in families, and families don't have to be your family that you were born into, but could be family of choice. And we have an amazing family of choice that supports us and loves us. And we also have our very close families, that also support us. So
doubly blessed.
Really blessed. And to have 3 families chosen, and our traditional family,
family we were born into,
sisters, parents, everybody except your dad that passed away. But I mean, we have all of that, and we feel so fortunate that we come up with some ideas that hopefully today will show you on how to really help figure out when someone is suffering, how to give them some internal light where they might not see it. Because when I was in my disease and I was out there and I thought everything was fine, because of my trauma, and I think this is really where it roots from. And you, as a clinician, you know that addiction is rooted from some form of trauma, and the trauma of being bullied. Then me figuring it out on my own per se, because I was afraid to ask anyone how to handle that. And so figuring it out. And then when you tell me when I get sober, or when I first went to AA at 19 years old, and you're telling me I need to surrender, what does that mean?
Doesn't make sense.
Yeah, right. I was like, how do I surrender when, I figured it out, since I was 14, I was 13, I was bullied, actually 4 to 13, I was bullied. And then I started doing drugs at 13. So I really helped figure it out, in my mind. And then at 19, they say I surrender. I wish at 19 I did surrender. I wish I would have done what people were asking me to do, but I didn't. I waited until I was 26 years old to surrender. And that was another, 7 years of suffering that didn't need to happen when it was first diagnosed and recognized at 19, but yet someone didn't know how to turn the light on for me in a loving, professional way and respectful way. And that's what we're here to talk about today, is really help people understand how to intervene, because that's where we're rooted from. We've been doing interventions. I've been doing them for over 20 years now, and we've been doing trainings for over 10 to 15 years. So that's really what our goal is today, is to give you some help to support those young adults or older, it doesn't matter, right?
Yep.
There's people out there in their 50s still doing meth. And I'm like, oh my God, you're a little too old for this, but they're still doing it. And I believe the reason why they're still doing it is because they're feeling the pain. They're still feeling that pain from their trauma that they haven't addressed. So that's what we want to accomplish today.
Yeah, and I think one of the things we want to talk specifically about is, we're fortunate that we're able to be intervention providers, treatment providers, as well as aftercare providers. And one of the things we need to focus on is how do we reach this population? Because unfortunately, it is typically an underserved population. And when we talk about intersectionality, when you factor in race, socioeconomic status, all those great social worker buzzwords, you really come up with a complex issue. So even being able to do an intervention might not be the easiest thing to do when you're talking about these populations. So we'll address that. We also, want to acknowledge that, for many people in our communities, we are in a time of finally feeling safe and taking a deep breath.
Recently. A couple days.
Yes.
A couple days.
As a big Twitter and Facebook person, a lot of the posts on social media from people who are in, historically oppressed communities, it's been a big sigh of relief. And we won't get political. We're not going to, discuss right or wrong, but we will say that this could be a really good opening for people. And Ken mentioned COVID, how tough the past year has been. When you couple those two things together, hopefully there's a light at the end of the tunnel for COVID with the vaccines, with new policy in place. We anticipate a surge of people reaching out and needing help, who've been greatly impacted from mental health, drug and alcohol issues. And then, as Ken said, how can we, one, identify that population, two, bring them the services that are so crucial, and then three, how can we support them long term? I think a lot of times, there's a belief that if we just get them the help, they'll be okay. But what we've seen in our experiences is yes, engaging in the help is critical, but what happens after that? What's the long-term support, and what kind of special issues do we need to consider when we're dealing with populations that are typically underserved? So,
and why people don't get it, right?
Yeah.
I mean, A lot of people don't get sober. They try and they try and they try. 10, 20 treatment centers you hear of. And then you hear of somebody at 17, 19 walking in the door and have 30, 40 years sober. So we want to help, number one, I think is the beginning of showing how to intervene. But number two is following up with the long-term aftercare, because that is the missing link. Treatment is good, treatment is great. And if we were to go to treatment together, one may stay sober and one may not, but it's not because the treatment was different. It was different as an experience for each one of us, because one of us was more motivated.
Yep.
And one of us was less motivated to be a sponge in water. So we want to show you how to motivate people to be that sponge in water, so they are digesting the treatment that they're both getting.
Yeah.
Does that make sense?
Absolutely. Absolutely. And so let's, we'll get started. We did a kind of an outline here. And we're gonna share our screen. All right. So, Renee mentioned about, kind of that we are typically at the front end of a lot of people's engagement in treatment. And we'll talk, when we talk about our model, about how to improve treatment retention, how to improve long-term recovery. We'll talk a little bit more about philosophically the intervention. But we want to kind of even talk pre-intervention now. And one of the things that, Renee mentioned that I'm sure many of the topics have addressed is, one, we have a crisis, and two, how do we help? So reaching out, how do we reach out? And then how do we hold on? Engagement and aftercare for the LGBTQi population. And all right, so what is it like pre-treatment for people or pre-intervention for people? As I'm sure many people have discussed this, we see higher rates and incidences of some substance use among LGBTQi, some upwards of, some statistics showing 30% of LGBTQI identify as having substance abuse issues, and about 10% of the overall population. So much higher incidence of substance abuse. We know about increased suicidality. One factor we don't often take into consideration is increased homelessness, especially among youth, which in itself is a barrier for treatment. It's really hard to go online and search for treatment options when you don't have a family that could support you, you don't have internet access to be able to do that, and you don't have a safe place to sleep until you can make it into treatment. And we see increased mental health symptoms throughout this population, in particular depression and anxiety, but all sorts of mental health symptoms. And some of the research out there, if we wanted to kind of pinpoint some of the reasons why we see this, this quote as homophobia, discrimination, and victimization are largely what's responsible for these substance use disparities. Ken talked about the bullying, right? As a young kid, as early as 4 years old, recognizing that he didn't belong in some way. And that was an external message he got initially, but coupled with the message that gay is wrong, that gay is unacceptable. And he was a young gay person a long time ago. So it was a very different situation back then. But when you compile issue upon issue upon issue, that barrier to getting help can be even greater to hurdle.
And you don't feel worthy, you don't feel like you connect, and that you don't feel like, why should I be able to get the help? God made me wrong. I mean, I don't know how many of you have been bullied, and maybe you can put it in the chat, if you've ever been bullied in the past. I think it's pretty common in our community, and but not feeling like God made me right. I mean, just knowing that God made me wrong for some reason. I don't know why God did this. God made me wrong, and I should be punished. I guess that was the message that was going through my head. I should be punished because I have these, this craving or this wanting to be closer to the same sex, which, you're taught in school, you're taught in religion, you're taught everywhere in society. That's not right, especially when I went through it in the 70s.
Yeah.
You know, and then in the 80s, it started opening up a little bit, but then, HIV and AIDS came along, and then it really made it, discriminatory, where, oh, you're going to die of that if you're gay. So all of those internal feelings that are brought in from society, that you're talking about, make somebody like, the people that we're treating makes them feel like they're an outcast. And especially, again, we don't want to get political, but especially with the last administration, 4 years ago, I was flying into another state and I was scared to death because I was like, these people in this state don't like gay people. And I'm so fortunate that, well, I think I could hide it. I think I could hide it, but most people know. But the reality is that, what about the ones like, I don't think I would have been able to hide it because as a young kid, I had to train my body to hide it. I had to train myself how to walk different, how to talk different, just so I wouldn't get bullied. I had to train myself. I remember being conscious. I can't do that. I have to walk differently. When I walk, they make fun of me and they say that I skip. So I have to, really concentrate on how to walk just so I don't get beat up. So the people in today's society, it's a little better, but yet it's really not. I mean, when you look at so many people that are so prejudiced and so, I think it's a million times better, but we have a long way to go.
Yeah.
That's the key.
And I think, Ken and I, being white, cis male, come from a place of privilege. And that comment about being able to hide it, there is a certain amount of passing that is much easier for us than there is for someone from a different racial or ethnic group, someone from who does not identify or maybe does identify as trans. There's a lot of privilege with what we get. But then when you use that like kind of idea of compounding, right? I'm sure many people are familiar with lots of studies that show that African Americans have health disparities as a result of the way in which people respond to different racial groups, racism. And I think that when you combine kind of a feeling of lack of self-worth from that core identity issue that you're talking about with other types of minority identifications, you really come out and see how powerful the society can be working against you. And that is another barrier to treatment. It's another barrier.
Moving right along here.
So why is engagement difficult? And I think that this kind of speaks to some of what Ken and I were already talking about. There is not a lot of attention paid to addressing people who aren't available for services. It's always much easier to be able to have someone coming to you looking for help rather than you going out and seeing people who actually need help. We don't have a great capacity, lack of infrastructure. There's a lack of information.
Finances.
Yeah, absolutely. Finances for people who seek treatment, and then finances to be able to provide treatment to people who don't have the financial means.
I want it.
And for, from a perspective of, I think we see this in the substance abuse field, is that oftentimes service is, hey, I'm your interventionist, I'm going to drop you off at treatment. And then the treatment center says, hey, I'm your treatment center, we're going to take it from here, and then says, now go home back to your community, which may or may not be safe, which may or may not know how to help you. And then you end up in your community and they're saying, well, what do we do with you now? And there's not a continuity of services. And this can be really challenging. And it's actually one of the key issues that we like to focus on in terms of making sure that not only we reinforce the intervention and treatment, but that we enhance the long-term recovery. So how do we overcome some of these obstacles? So here are some ways, specific ways in which you as a provider can go ahead and be able to reach out to populations that might need it. Think about where you're advertising.
Yeah.
Oftentimes Ken has always been a proponent of, advertising in LGBTQ themed areas, magazines, TV, newsprint, any of those things that reach that population can be really helpful. Collaborating with community providers. We are blessed here in Palm Springs to be able to have community providers like DAP, the Center, all of which provide services to the LGBTQ community. And when we partner with them, we find that we can have a broader outreach. I know Bill is here on the presentation, and he's a great example of how well some community partners do outreach. We have to make our presence inclusive. That means not only providing examples of how we're inclusive to our clients, but how we're inclusive from an employment standpoint. Hiring and developing populations that are typically underrepresented. We can seek funding from government agencies. This is a key one. Many places say, oh yeah, we offer scholarships, and then, oh, the scholarship bed is full. We have to hold, offer, and fill space for people who endure financial hardships or instabilities and meet the criteria of the underserved populations we're trying to meet. The other two kind of go hand in hand. We need to, and I think this is where, from an intervention standpoint, this is where it's really exciting for us is, sometimes you have to meet people where they're willing to come to, and then be able to support them with the intervention and the long-term case management process. So if someone's not ready for treatment, but maybe a lower barrier entry point like MAT or sober living or outpatient, you can't take an approach where you want to lessen what you offer just because someone's not ready to do kind of what you would anticipate as the number one kind of solution. And then I think for communities of color, for communities of LGBTQi communities, we really have to promote harm reduction for those people who aren't ready to make the choice to use. Because again, this is another entryway in which we can meet people where they're at and start the intervention process and increasing that motivation to seek help and seek treatment. So we take a look at what happens when people get to treatment. I looked at some other fields, and in women's reproductive health, as well as nursing homes, here are some of the reasons people were saying that it's difficult to maintain relationships. And, I know there are many people who are probably speaking this weekend about this. How do we make our workplaces inclusive? But it's really important to think about how once we do engage someone, we don't send them running. Having had multiple, we at our treatment center at Kansas City Rehab, we have a lot of options for people who identify as trans. We don't insist that someone who identifies as female lives in a male sober living because that's their birth gender. We allow people that choice. So these are some kind of areas or stumbling blocks that we can get to. So we want to take a look at what is recovery post-treatment and what are some of the challenges that people come up against. It is really difficult. One of the things that we preach about the intervention is the family involvement, right?
Yeah, and I think it's more important. Let's go back a little bit and talk about the intervention. I think one of the most important things is, if any of you are familiar, I mean, this is a room of professionals that we're all working here, but a skilled interventionist is going to know about a genogram. Mm-hmm. And, you know, when you do a genogram, I'm getting ready. I got my bags packed right there. I'm heading out to do an intervention right now as soon as we end today for 11:30 flight. But before going into it, I'm interviewing the family system and mentally doing a genogram.
Mm-hmm.
And I'm realizing that this mother has suffered from mental health issues. So no wonder one son died from the disease and the other one's practically almost dead, you know, on heroin right now. So I'm heading up to Vegas to work with this family. But the reality is really having compassion and respect for that mother. She is in a lot of pain, but she caused a lot of trauma to her kid or her kids or whole family.
Yeah.
She would say, we're having tomato soup for dinner, and she would put ketchup in water, and that would be their meals. And so there's a lot that we could, you have to do as you intervene, is you really need to understand and have empathy for everyone involved and really see where they're coming from. And that mother has been diagnosed with mental illness, and now she's crying, wanting me to come in and help, you know, because her other son's on the edge of dying. And they have a couple other siblings that are going to be there at the intervention. So the point being is, when you do an intervention, it's about gathering all the information, understanding where everyone's at, and not only getting help for the identified person, I'm getting help for that mother too. Because like Eric said earlier, if I don't do that and he goes to treatment and he comes back to this unhealthy family, it's going to be easy for him to fall back into his disease.
Yep.
So before we get to the aftercare, I just want you to see the bigger picture, where we're not when we do interventions now, it's not about intervening on the identified person. It's about intervening on the family system. And anybody that needs support and help, we're going to make sure that they get it. And the tie-in, I love it, because this is when they're in crisis mode, when they call us for an intervention, when I say, what are you willing to do to help them? What?
Crickets.
Anything.
Oh, anything, yes.
No.
Well, what they say and what they do is two different things.
But what they'll say in crisis mode is, I'll do anything. And while they're in crisis, that's a good point, Eric, because after the fact, if I wait till after the intervention and I say, oh, you got to go do A, B, and C, because we had this with you know, somebody, a client, and they were like, well, it's really not my problem. It's my husband's problem. And, you know, she wouldn't get the help. That's why it's important to do it when they're in crisis mode. When they're in crisis mode, they're willing to do anything. So when I sit down with mom, I'm going to say, what are you willing to do? Anything. I don't want to lose another son. Great. Anything means that you're going to treatment. Mm-hmm. And that's the key. And when she says, no, I'm not going, I don't need it. Well, that's what your son's going to say. And are you going to lead by example this time, or are you going to lead? And then going in and saying, you know, in a loving, respectful, honorable way, saying, you know that you have mental health issues. Let's get them taken care of. You're asking your son to take his issues taken care of. Why wouldn't we take care of yours? You know, lead by example, be the mother, step up to the plate. And when you do that with empathy and compassion, you normally get the good response. And now you're getting a family into recovery. So that's prior. And then they get into treatment. They all do their treatment. But this is where the ball drops, is they're all finished with treatment. And then it's really hard to keep on track after treatment, because our old blueprints that are stamped into our brains are telling us to go back to old traits, old behaviors. So how do you stay in recovery? You know, they tell you to get a sponsor, an AA. And yeah, that's great, but that ain't mandatory, or there's nothing pushing you to do that. So this is the point where we're at, is how do we push people to stay in recovery with a loving, gentle hand and stay following the treatment recommendations that they received while they were in treatment, I think is the key component, because that's where we're all dropping the ball in this industry. If we were able to follow them, like we'll talk about it, high licensed professionals for 5 years, we'd have a better outcome.
Absolutely. And I think, you know, one of the things, and we've seen this in our own practice, is that sometimes you have to kind of rethink family, right? When we're talking about populations that historically have been shunned by their families, or may not have families, or may have different families of choice, how do you navigate, you know, the mom who might be fundamental Christian and doesn't believe that her son is gay, with, you know, his partner who is, you know, begging for our help because you know, his husband has a crystal meth addiction, and balancing those two things, you know, can be very, very challenging, because there's sometimes opposite goals.
Yeah.
You know, and
Totally.
what Ken's talking about as part of that pre-intervention is getting everyone into agreement and on the same page, and being mindful that not everyone is capable of having the same view or the same kind of feelings, but when you bring it down to your loved one is suffering, let's get the help that they need. That's really a unifier. Yeah, it works to unify the family system.
And I know a lot of you, you know, have watched Pose. I love that show. But, you know, that what they're telling us there is that's a family of choice.
Yes.
They have what is it called? The mother?
The mother, yep.
The mother that runs the house. And that's a family of choice. And a family of choice, I think this would be a test if there was a test question, if there was an exam after this. But the family of choice, you know, if that's a family of choice, you know, can you do a professional intervention with a family of choice?
100%.
You know,
100%. I think I'm not as big a fan of Pose, but I do seem to remember an episode where one of the mothers was upset because one of the children was using.
Yeah.
And while she didn't do an intervention, she circled the wagons. It wasn't a formal intervention like calling an interventionist. She kind of circled the wagons and said, "We're not going to tolerate this behavior anymore.
Get out of my house."
And get out of my house. And that is, you know, that's a great kind of approach. And we would encourage us, you know, people to think about taking that to the next step. How can we support that?
Professional.
To have a professional who can help you, not, you know, for people, especially people who have been rejected by their own parents, to be told, you know, get out of the house, you can't stay here, can be like a double whammy, a second trauma. And that's not always the best choice. And a lot of times with interventions, people think, oh, you're just going to come and tell them no money, no food, get out of the house. But we very rarely actually even do that.
No.
I think that that's, you know, kind of the exception rather than the rule. And there are, the way in which we consider interventions is we look, what's going to motivate that person to change? And then how can we present that in a loving and respectful way and say, look, we have a choice today.
Yeah.
You can either come with us, get the support and help that we know you really want, or, you know, this is what life could look like. And that's a very delicate balance. And, you know, we don't, it's a lose-lose for a mom to have her kid out on the street. He's feeling like, see, they never loved me. And she's feeling like, oh my God, I'm so worried what's going to happen. That's not a true intervention.
Yeah. And I love it because, you know, intervening on somebody that's a codependent, like if there's an outsider, you know, this is a little off topic, but there's an outsider that doesn't agree with the rest of the family system, you know, and I love to give this example because it was one of the cases that I did where the mother was like, I don't mind if my baby son stays with me and gets high. You know, I bring him home his medication. She was a nurse at the hospital and she would steal drugs from her work. She'd bring him home. If she couldn't get enough, she would get him on the streets. And so what the rest of the family did is went to her and they intervened on her. Remember, it's a family disease. It's a family illness. So even if it was mother that was at, you know, the apartment that, you know, on Pose, it's still, if there's one person that's sick, you could intervene on them too to stop enabling. So this mother, her drug of choice was her baby boy needed her at 40 years old, you know, and her,
he was 40.
Yeah. He was 40, exactly. Not mother, he was. And baby boy needed mommy, and mommy was addicted to having to help her baby. And, but she loved her grandchildren more than anything, his kids. And his wife said, if you do not support us, I am going to take away your grandchildren and you'll never see them again. And that meant something to her to say, oh, I'm not going to do that. And then the icing on the cake was, and then I'm going to report you to the nursing board because you're stealing drugs from work and giving it to my husband. And you will lose this lifestyle that you're accustomed to because you will lose your license. And the minute she heard those two consequences, she was in complete compliance.
Yep.
I will do anything to help save my son's life now. But she was very comfortable for years keeping him on the couch doing drugs.
Yeah, and people get stuck into thinking this is better than him being out there. This is better than X.
Dying on the street.
Yeah, and unfortunately, some of that perpetrates. There's that balance between we want to keep our loved ones safe, and then how are we potentially contributing to their death? I mean, this statistic shocked me when I first heard it, but that a significant portion of overdose deaths for young adults happen in their parents' home or in hotel rooms that are paid for by the parents. And that's the reality of where we're at today. I mean, we're seeing an increase in overdose death. That's a whole other issue, that we talked a little bit about in terms of, making things safer for people. And we won't get into that here, but, I think that we have a big task ahead of us, and whatever we can do to help more people, better.
Sorry for off track,
Yes.
but now let's get back on
right.
the agenda.
Yeah, and so, in terms of from a post-treatment perspective, Ken and I often talk about this idea of what works and what doesn't work in recovery. And this is, we feel that this approach is effective at reducing barriers to recovery for all populations, not just LGBTQ. And what we'll do is we will talk specifically about some more pressure points that you might want to be concerned about when dealing with LGBT.
And cautious about.
Yeah, but we want to give you kind of like a recipe that hopefully you can implement in working with any population, because what we really want to look at is, getting people to recover. The intervention gets someone to the recovery door, and how do we hold their hand, walk them through that, and help them with long-term recovery. So you want to talk a little bit about, we didn't practice this part, so who do you want? I'll do drug courts.
Sure.
All right. So, one of the things is, many of you work for facilities, many of you work in the field. You probably have seen a website for a treatment center that says we have an 85% success rate. And, maybe you've been to peer recovery groups like AA, and maybe you've seen literature that says we have a 2% success rate. The reality for us in our experience, and substantiated through follow-up aftercare, is that when people only go to treatment, when people engage in a detox facility, or when people go to 30 days of treatment, we are not seeing outstanding success at the end of that. If you look at a year post-treatment, if people are still sober, if people report higher quality of life, it's not happening. It's not happening. So what we've always been interested in is, well, where do people complete treatment and stay sober a long time? And we had the good fortune a couple of years ago of meeting one of the judges with the Brooklyn treatment programs. And these are diversion programs, and we're not going to talk about the efficacy of mandated treatment in general. But what we will, or whether someone should be forced to go to treatment when they're in jail, whether that. What we are going to talk about is the idea of an intervention and how that can impact long-term recovery. And so what happens is, the drug courts come in. Bob gets a drunk driving, and he goes before the court, and the court says, hey, look, clearly there's an issue, right? This is your third drunk driving. You have a problem with driving under the influence. we are going to offer you the opportunity to go to treatment to avoid sentencing. And when that happens, there's a whole protocol in place, and we'll go more into detail what that protocol looks like. But for the drug courts, it's basically, appropriate level of treatment, evidence-based treatment for a duration of time, accountability to that program of recovery for anywhere from 18 months to 24 months, and then someone who kind of oversees the progress through that continuum of care. And drug courts, depending on which drug court or where, generally range between 18 months to 24 months. And they have a non-recidivism rate of about 60 to 65% after that 2-year marker. So that's a big increase from what we're seeing. When someone goes to 30 days, they don't follow aftercare recommendations, they don't stay engaged, and then they end up relapsing. We're seeing improvements of about 60 to 65% in abstinence. Now we're measuring abstinence, and there are lots of other measures that we could talk about right now, but did you want to go?
Yeah, and then when you look at the doctor diversion programs, I mean, I know a lot of physicians that got sober in the doctor diversion programs, the nurses, the pharmacists, all these high licensed professionals, the medical field, they have that diversion program. And it was created, back in the 80s. And the reason why I know it's back in the 80s, because before I got sober, I have a friend of mine out of Miami that he was a physician that got sober through the doctor diversion program before I got sober. And I got sober in 1989, so he got sober before that. So the doctor's diversion program has been going on at least since the 80s. And the reason they created this is because the doctors, didn't want them to create harm on their patients if they were under influence. And so they ended up creating this formula. And, as John Southworth, love him, he's here with us, I'm sure, listening, guiding us through this, saying, shut up, tell them this. But this is one of the things he would say is, what they did is they followed a formula, and he would call it as baking cookies. And the formula is pretty simple. But if you complicate it, the formula, it's not going to work. And he would allude it to as, if you're baking chocolate chip cookies and you leave the flour out, what is it going to taste like?
Well, it may taste good.
He eats it without the flour.
I'm a butter and sugar fan, but it certainly wouldn't be a cookie.
Yes, it would not be. It would be syrup, right?
Yes.
So, or leave the chocolate chips out, or leave the sugar out. Now, what would it do?
You've ruined Christmas for the whole family.
Now it's destroyed, right? No sugar in your chocolate chip cookie. So
now, mind you, I'm sugar-free 6 months, so I'm a little more comfortable with that thought now.
But devastated over it. But that's the reality of it. It's that simple. And their formula for their recipe is, you go to treatment for 9, they intervene. So there's an intervention where the licensing board intervenes. They either do it or the physician or nurse self-reports. And if they self-report, it's the same thing. They're going to expect the same thing out of you, but there's less consequences towards your licensure by self-reporting.
Correct.
So it doesn't matter if your colleague turns you into the board or you turn yourself into the board. What matters is that's the intervention. That intervention holds somebody accountable to your recovery. So like my friend that did it, 30 plus years ago, the board had a case manager following him through this process. So you get the intervention, you go to treatment. After treatment, they follow you. And it used to be 3 years, but they realized the doctors were holding their breaths for 3 years, and they raised it to 5 years. And what I mean about holding your breath is that minute that it was released, and they didn't have to abide by their contract in order to work, they would relapse. They would go back on drugs or alcohol. But what they realized in this recipe of years of experience, that after 5 years, the doctors wanted to stay sober.
Yeah.
They didn't want to go back on drugs. So they realized that was the point that was important for them, that now it's a 5-year protocol. But what they do is during that 5 years, after 90 days of treatment, they're getting randomly drug tested. They're going to some form of support group, AA, smart recovery, some kind of support group, your church, whatever that is for them. You're getting randomly tested. I already said that,
Yep.
right? Randomly tested.
Ongoing therapy.
Medical peer-to-peer support groups. So you'll go with your colleagues and do like an AA meeting, but with them, with a facilitator. So you're doing that for 5 years. And if you're in breach of it, this is the important part. If you're in breach with it, the stick comes in. The stick is the licensing board saying, you didn't show up for your test, or you didn't show up to your group therapy session. If that happens, then there's an immediate intervention. They don't turn a blind eye and say, oh yeah, that doctor will be fine seeing patients. Who cares if he cuts them open? No. It's black and white. It's you're in recovery or you're not in recovery, just like you're pregnant or not pregnant. There's no middle land. And they work with them and they say, okay, now that you're out of compliance, there's going to be an intervention and there's going to be a consequence. And then let's get you back into compliance. And it's just like Joint Commission when they come out and audit their discrepancies that they put together. And I think some people get 30, 40 of them. I think we got like 3 or 4 the last audit we had. But you correct them. It isn't like they pull the license and say, or the certification with Joint Commission, and you don't have it anymore. You get a time to correct them. And that's the same thing with the doctor diversion program. And that's a skilled case manager interventionist.
Yep.
Because it's not about being punitive and shutting them down because they're non-compliant. There's something missing. Maybe they're not getting enough treatment or therapy, or maybe there was a crisis or something might have triggered a trauma that happened and you need to redirect and re-guide. But that's why treatment doesn't work. People hate when I say that. Alone, I'll add it, alone, because the clients don't have the recipe that the doctors have, that they have this continuum of care, of support. And I look at it like a trainer at the gym. If you want to change your body, you hire a nutritionist to change how to eat, your eating habits. You hire a trainer at the gym. You hire these professionals to guide you through those processes. This case management, the missing link in most situations, this case management that the doctors have, keep you on track to make sure that you could complete your 5-year program and continue to live that lifestyle that you deserve and you worked so hard to obtain. I think that's the key component. It's right there. It's that simple.
Yeah. And you bring up a good thing. Many of you, or I don't know, I can't see anyone else, so I can't tell, but many people struggle with weight, and it's the same thing. And they go up and they go down and they go up and they go down. And why? Because our motivation goes up and goes down. Our motivation to make that sacrifice of only eating salad with no dressing at the specific time in the specific amount. Sometimes I want a pepperoni and cheese pizza, and sometimes I'm going to have that pepperoni and cheese pizza.
But no chocolate chip with sugar.
No sugar. Keep your fingers crossed. It's been tough this week. I've been craving, but it's that accountability piece is so powerful for any type of recovery. And it goes, yes, extra cheese, absolutely.
Thanks, Bill.
And it is about, like Ken said, the diversion programs aren't perfect, right? They have not. There's been some slow time to come up to more kind of new thought around medication management, Suboxone, other types of medications for cravings, and there is some work that we can do on that. But what we're talking about is we're talking about the components that Ken just was talking about, all those different components. How do we envision that for the clients that we work with, and specifically what might be some high pressure ones for LGBTQi? It's great to want someone to continue with therapy, but if they don't even have housing, and we're not considering housing that's safe and secure for them, that's going to be a big issue.
Yeah. And like Lauren just said, I love that, Lauren. And keep typing in here if you have any questions or any comments, because we're seeing them right here in front of us. But, Lauren's right. These doctor diversion programs, we just had a couple of case managers come to our training this past weekend. And what they learned is the importance of bringing the family system in. So really having the training to understand that it's important, not only what the doctor diversion program has been working so well for over 30 years for high licensed professionals, but the missing link is if they bring the families in, again, it's a family disease. Now we're going to increase the rates even higher.
Yeah.
So doctor diversion programs, I know, the doctor that worked with me in Mississippi was Scott Hamilton, and he oversees the doctor diversion program over there. And he told me it's very clear that addicts do not get sober without consequences, period. He said, stop sugarcoating it, Ken. Do not, I used to call it healthy consequences, or, you just got to motivate them. He goes, stop sugarcoating it and tell them the truth. And the reality is every single addict out there has to have consequences to get sober. And if you look at it, with 31 years of sobriety, getting sober in 1989, I've been to a lot of meetings. I still go to a lot of meetings, and speaker meetings talk about what it was like, what happened, and what it's like today. And when they talk about what happened, after they, what happened in their disease, what it was like, what happened, what motivated them to want to change, it's never not been a consequence. Never. Never.
It's sunny out. I think I'll go to treatment.
Yeah.
That doesn't happen.
Oh, we're moving to Hawaii? Oh, let's
go to treatment. No.
It doesn't happen that way. The reason why people get sober is because they feel discomfort. They don't get a raise at work. They don't get engaged. They don't have a new spouse. None of that is why people go into treatment and get sober. They felt a form of a consequence that motivates them. And so as we move on with this presentation, I want you to know that, some people, as they say in the program, are sicker than others. And some people are going to take a little bit harder with the stick. Dr. Scott Hamilton talked about it as the stick and carrot. You need the stick to keep pushing them, but you need the carrot. So sometimes the stick isn't firm enough. So he said, I think there was a low percentage, but some percentages of the doctors decide to turn in their licensure. Mm-hmm. And they decide, I'd rather not practice than go down that road. But that means the licensure wasn't a hard enough stick. But if we could bring the family in, and maybe the family could help support creating the stick a little bit more aggressive or firmly to get them motivated to want to change. I think that's another missing link that we all have, is that we got to be clear. Nobody gets sober because it's a great day. They may say they want to get sober and they did it because they chose to get sober. But if you really dig and you really find out, a good therapist would be able to figure out really what was the motivating piece that made them want to get sober. And if you ask every single client I've ever come in, or every peer, every single person I've ever met that's in recovery, it was something that was painful.
Yeah. And I think people have a hard time with this. And this is the kind of the piece in which we base our intervention work on, is that moment of change, that opportunity to do something different. And Ken's right on spot, where it's a stick and it's also the carrot. And we talk a little bit about that in our long-term approach, that anyone who's been hit by a stick knows if you have too much stick, it's not going to work. So we need to,
Punitive.
yeah, we need to have those carrots. We need to have that light that people seek. I know Irish is on the in the chat, and you think about someone who exudes such a positive light and someone who is so positive, and that's that carrot. That's that kind of reaching for, I want something better for myself. And it's important to realize, the drug courts have the judge, the doctors have the medical board, the pilots have the FAA, and unfortunately, most people aren't part of a licensure, right? So what do we
Or
have?
convicted felons.
Yeah. So what do we have? You have the board of family, and that's what we're talking about at the intervention, is creating that board of family. And we want the IP, the identified person, the person who's actually, exhibiting the drug use or alcohol use behavior, to be part of that team. It's critical. This isn't a us against them. It's a we're all on the same page, and how can we support that moving forward?
So even if it's you, mother, in Pose, it could be you. You could be
Yeah.
the motivating factor.
Yeah, and if anyone's up for it, if you want to share, if you identify as being in some form of recovery, and share or don't, but maybe think, if you can think about, as we talk about this moment of intervention, this moment of change, what was the thing, how could you qualify, what was the thing that made you
Or
say,
things.
I'm going to change today? For me, it was my job. I got caught at work by someone who I supervised using crystal meth. I had been at work all night. She walked in, I had powder,
Sugar.
well, I wish it had been sugar, but I had powder, crystal meth around my nostril, and there were no jelly donuts with sugar on them anywhere in the office. And she kind of gave me this look, and I didn't realize that I had it on my face, and I kind of, didn't think anything of it. And I went to the bathroom and noticed, and had that been my boss, I might have had a very different outcome. But fortunately, it was kind of like that kick in the pants. And there were other things as well. I wasn't talking to my family. I felt miserable. I was having consequences, emotional consequences, mental wellness consequences, but it was that work thing. I loved my job. I did events for Warner Brothers Studios. It was like a lifelong dream to be doing what I did. And the thought of losing that was enough. I didn't have to lose my job. So maybe if people want to share what their kind of, we can call it a rock bottom, their consequence, their motivating factor. If you feel comfortable, share that in the chat. Go ahead and do that. So what the doctors who participate in the program 5 years, what's their success rate?
I think, if a lot of you know Dr. Greg Skipper, and I know he keeps a tally on that, but I think it's like 80 to 85%.
Yep.
It's pretty high. When you look at traditional treatment, I know you all know it's 30 days of treatment is 3 to 7% success rate, 3 to 7, and then you're going to jump to 80, 85, and the drug courts, as you said, 60 to 65. So now from 3 to 7, what is the missing link in the two, from the everyday person, the lay person that doesn't have a licensure, or the person that doesn't want to be in drug court or have a felon? Because the other part that the judge will do is, if you have a felony, they'll drop it down to a misdemeanor if it's drug, induced by attending this program. So what are we missing here? The only thing we're missing is
the accountability to a program of recovery over a duration of time.
Yeah.
And that's a big thing to be missing.
It's big,
Yeah.
but it's simple.
Yeah.
When you look at it in that light, it's really not that complicated. It's really not that hard. And we should be giving every single human being out there the same exact treatment or formula or recipe, or whatever you want to call it, the same treatment that doctors, nurses, lawyers, pilots get.
Yeah. And the nice thing is you can take those recipes, and you're crazy, but people who like oatmeal raisin cookies, they can adjust.
Love them.
Not fair. We might have to divorce. Good thing I'm not eating sugar.
I don't eat sugar either.
But you can have different. There could be different ingredients, but the fact is you have to have all the ingredients. An oatmeal raisin cookie without the raisins might not satisfy in the same way as it does. Going on to pilots, it's very similar. There's a big study called the HIM study. And that study shows the biggest difference between the pilots and the doctors is the pilots is 10 years. So you're monitored for 10 years. And if there is a relapse, then you're monitored for the life of your licensure. And they have a success rate from, again, talking from an abstinence-based perspective of 92% stay sober after 10 years. And that's outstanding. You know, why couldn't everyone have that opportunity for recovery? So we'll talk a little bit about kind of more specifically those components next. All right. So here are some components, and what we've done is I've kind of adjusted these for some of the concerns that would be critical for people who are identify as LGBTQi. But for the most part, they're exactly the same as what you would see for anyone. What we talked about being part of the drug diversion program. You know, an important piece, which we've talked a lot about, is that intervention piece, and whether that's something that occurs now. I love the way you talked about that, Ken. Sometimes interventions happen on their own, right? Someone shows up at your door at treatment. Someone shows up at your office if you're a therapist and says, I need some help. I want to stop using. I can't do it on my own. But I know I need help. And what Ken tapped on was, if we come from the perspective that everyone has had some sort of internal intervention, and we can dig to find out what was it that happened? What was it that made you say,
That's a good therapist.
I'm not gonna use drugs? Boy, what a clue you have to how to work with that client moving forward.
And keep them motivated.
Keep them motivated.
Keep them
Exactly.
motivated. Oh, remember why you came in to see me 3 weeks ago? And that's still going to disappear, and your family's not going to be a part of your life because you're deciding to go back on drugs. So remembering that and realizing that that's a key component in treating that patient.
Absolutely. And one of the things that we do at our center, because we so strongly believe in the intervention model of leveraging a person's willingness or readiness to change, is we incorporate and involve the entire family system. We actually had someone, speaking of an LGBTQI population, we actually had someone who didn't have any family member who was part of that intervention. The only people that were part of that intervention were his girlfriend, some of the people that he was in the military with, as well as some of his LGBTQI community that was still active in use, but were able to participate in a healthy way to support his intervention process. It was really incredible to see and to think about how when you use the perspective and when you use the model, you can apply it almost anywhere.
And that one that one you'll be able to see on A&E's intervention show, because he came to our treatment center from an intervention from the show, and he just left, and he did extremely well. And like Eric said, he didn't have any, family. It was all family of choice.
Yep.
It was no family that he was born into that was part of that intervention process with the show, and none of them that showed up while he was in treatment either.
Yep.
It was all of his friends from the military, his ex-girlfriend, his little boy. That's what motivated him to want to get into recovery. So that was a good point, and you'll be able to see that one, I think, in March or April on the show.
All right. And so, there's some form of treatment typically. I think that when we talked earlier about kind of the willingness to kind of meet people where they're at, I believe in my experience that having, kind of a 90-day model of detoxification, stabilization, and being able to have that support is critical. But this model can be used with wherever anyone is willing to enter treatment. So if someone is willing to enter treatment from an outpatient perspective, from a MAT perspective, you can still apply this model to helping them regain recovery. We're not here to judge someone. I mean, I'm a big proponent of people identifying as sober who are on medication-assisted therapy. as long as they're not using other drugs and alcohol. I think that we have to do that. And there's some debate in about that. But from our perspective, we cannot be inclusive unless we allow multiple pathways to recovery. Maybe that's a good way to say it. So treatment, we define as detox residential outpatient, but can look a whole lot of certain ways. We've highlighted this in red. We hope that you kind of understand, if you take nothing else away from this is that
on the test.
It's on the test. Yeah. It's an ongoing, seamless, long-term support. There is nothing better than allowing someone the opportunity to be supported through their recovery experience and help them transition from intervention to treatment to aftercare. It is really, really critical and crucial, and probably one of the areas in which we do the worst on from
in the industry. Yeah. I mean,
it's not great. Their post-treatment, obviously we want to make sure that we include therapy. That could be individual, that could be group therapy. It can be, how we help with a person from LGBTQi is make sure that person is inclusive, make sure that person understands LGBTQi issues, medication management, family support. These are all things we've talked a lot about. Engagement in peer recovery, again, multiple pathways. We're not talking AA, we're talking about some form of peer recovery. Safe housing is a really big issue, particularly when we talk about our young adult who come in and are homeless or vulnerable to being in housing situations with people who are predators. It's from a community perspective, we have to have safety around that. It can be job training and support. It can be education, physical health and well-being. We really are firm believers in testing and accountability, and then supporting work. What are vocationally people looking at? As far as how to make sure that you're LGBTQI inclusive are the referrals that you're making, are they experienced with the LGBTQI community? Do they have the ability to meet their needs? Are providers also members of the LGBTQI community? For some people, that's a big thing to have that identification. But all of these are the various components of a 5-year plan. And if we talk about this and we support this and we bring this in and there's nothing worse than telling someone who's a little unsure about getting into recovery, oh, we've got a 5-year plan for you. Woohoo! This
is going to be exciting.
Yeah, that doesn't go over well. But if we think about, how people recover and where people see success, when you look at the cancer recovery models, people know what a 5-year, meeting the 5-year cancer-free mark, the 5-year survival rate, and the importance of, do you want to talk about your mom?
Yeah, no, I love that, and that way of looking at, this is a terminal disease that's killing how many people every year, like hundreds of thousands, right? And every single year, and this year it even increased. But when you look at cancer, I am so grateful, I would say probably over 20 years ago, because we've been together 16, my mom had breast cancer. And with breast cancer, even 20 years ago, they had this myth that this treatment plan, that if you stayed in remission for over 5 years, then that means that you're cancer free. And what that also means, again, 5 years, no coincidences, the doctor diversion program, the cancer 5-year survival rate, no coincidences. These are both medical issues that have medical consequences.